Well, good afternoon again. My name is Sarah Giannetti. I work at the Ohio Department of Health, and I'm also a member of ONIN. Welcome and thank you so much for joining us today at the 2022 Ohio Nutrition Incentive Network Annual Convening. We are very excited about the series of sessions during this convening and hope that you will join us to learn about the many organizations, projects, and programs that create Ohio's local food system. You can still register for any session, and we'll share session titles and links to register in the chat box now. We are beginning each session with a land acknowledgement, which we have sourced from the Ohio State University Office of Diversity and Inclusion. A land acknowledgement recognizes and respects the relationship that exists between Indigenous peoples and their ancestral and contemporary territories. We acknowledge that the state of Ohio occupies the ancestral and contemporary territory of the Shawnee, Potawatomi, Delaware, Miami, Peoria, Seneca, Wyandot, Ojibwe, and Cherokee peoples. These lands were ceded in the 1795 Treaty of Greenville and the forced removal of tribes through the Indian Removal Act of 1830. We would like to invite you to add your pronouns to your displayed Zoom name or share them in the chat box. If this is your first session today, the Ohio Nutrition Incentive Network is a multi-sector coalition working toward a shared vision of affordable access to healthy local foods and a healthy, equitable, and resilient Ohio food system. We represent diverse regions of Ohio and collaborate to advance nutrition incentive programming statewide. We will be sharing a full contact list early next week with recordings and notes from all sessions. Today, ONIN members have the ONIN background and have included ONIN in their profile names. Our network is looking to expand and diversify. If you are interested, please contact Anna Bird at Produce Perks Midwest, and her email can be found in the chat box. So now it's time to begin the content of our session. We have reserved time at the end for question and answer. ONIN members are also monitoring the chat throughout the presentation. Healthcare systems are recognizing the opportunity to improve patient health outcomes and reduce healthcare costs by implementing interventions which aim to reduce chronic disease conditions and address the social determinants of health. Social determinants of health are the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health can be grouped into 5 domains: economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Healthcare providers have a unique and important role in impacting patients' behavior through encouraging the consumption of healthy foods and linking patients to nutrition education resources. Today's sessions will provide an opportunity for some of our healthcare partners across the state to highlight their food system and nutrition security work. Today, we will hear from Gina Hemenway, Executive Director of Community Health with Mercy Health Cincinnati, Courtney Hudson, the Community Outreach and Education Manager with Akron Children's Hospital, and Leach, Director of Clinical and Community Nutrition with University Hospitals. And I will turn it over first to Gina.
Perfect. Thanks so much, Sarah. I'm going to go ahead and share my screen because I do have some slides. And I guess just anybody give me the thumbs up if they can see them.
Yep, we can see them.
I will go ahead and throw it into a slideshow. It's really nice to be able to share space with all of you today, albeit virtually, and be a part of this really important discussion. I know when we were on our planning call, we said, as health systems, we are kind of in a learning orientation as it relates to the food system. So as much as I am really happy to be here to share a little bit about how this work is showing up inside our organization, certainly equally excited to hear from all of you around, what you wish the health system knew about your work and the ways in which we could possibly collaborate more deeply. So I know we'll have some time to get into that discussion a little bit later. I threw up front here just a quick schematic, a map, and some stats around Bon Secours Mercy Health. So Mercy Health Cincinnati is part of the larger Bon Secours Mercy Health system, which is one of the top 5 Catholic health systems in the country, largest. But you'll see while we span 6 states, there's a really strong presence here in Ohio. So 6 of our 12 markets are actually in the state of Ohio. And we are a mission-based health system. So I always like to get this up front here too, acknowledging that while we provide clinical care, our sole purpose is not that it really is to improve the health and well-being of the communities that we serve. And so I think all of us can appreciate that in order to effectively do that, we have to think beyond the doctor's office and the hospital. And so being able to enter conversations like this, where we get to learn and live alongside partners who are thinking about that work in their communities, is really, really important. For us on the Mercy Health, in the Mercy Health system, a lot of this lives within our community health team. And so I gave just a quick overview of the work that our community health team does. And for the benefit of this group, I also put some asterisks next to some of the work that is required for nonprofit hospitals. And so I think that while certainly the origination of all of this that we'll be talking about kind of lives in our larger mission commitment, I think it's worth acknowledging that, to get the generous benefit of tax exempt status, there also are some requirements. And so while this work is likely organized differently in all of our relative health systems, kind of as evidenced by the variety of folks that you have on the call here, there are certain things that live within all nonprofit health systems. And so when we think about our role as a community health team, we're engaging our community stakeholders on an ongoing basis, but certainly very deeply on a 3-year cycle when we do our community health needs assessment. And that is really an opportunity to invite perspective from the communities we serve, with intentionality around seeking out the voices of those that are medically underserved, historically marginalized, where we populations in places with known health disparities, to appreciate and understand what are their health priorities. What does health look like in their homes and neighborhoods and communities and schools? And if they were to invite health system response around several of the many needs that we have, what would they prioritize? And so once those priority needs are named, it then becomes our job to think about how we respond and to, in the most simplest form, answer the question, will you address this? And if so, how? And if not, why? And that becomes an accountability measure for us. How will we demonstrate the investment and the impact that we have through our community benefit contributions? And so a lot of that exists within every nonprofit health system, just variably probably in how it's organized. The next piece of this is partnering with our clinical and operational teams to really think about how we become a conduit for community and community-based supports. And so I think, talking a lot about, screening for social determinants of health in clinical care settings and creating connectivity to the right partners and programs that can support those needs. But certainly our team sees this connection as, bi-directional. We also have plenty of partners who leverage our community health team to find their way into the organization, our HR teams to find employment opportunities, and other things in that nature. So quick snippet there. I gave for this group the needs that are identified in Southwest Ohio. So in Southwest Ohio, all of the health systems and health departments come together to complete the community health needs assessment. And so there's a single set of health priorities that are named for our region. I gave some historical context here because I think it's really exciting to see the way this is moving. And I think, again, gives substance to the space we're in here today to say that in 2019, which is just 3 years ago, this is still a little bit clinically focused, a little bit more condition focused. And then as we look at what was named in our 2022 needs assessment, you're seeing access to care remain kind of at the top of the list, but also this very specific focus on the social determinants of health and the explicit naming of both food and housing as an area for health system response. So I think that's an exciting shift that's happening across the country and certainly was codified into our needs assessment in Southwest Ohio. Oops, I'm not advancing. Hold on just a second. So as we start to think about this work, especially as it relates to the social determinants of health, we're really trying to embrace an and both orientation here, thinking about, the social needs or symptoms of some of our larger systematic problems, and how this might present for individual patients in our clinical care facilities. So appreciating that we have folks that are entering our doors with physical health needs, but also a myriad of social complexities, and how are we identifying those social challenges at the individual level and potentially putting programmatic or immediate responses in play to support them. I think that's a really important part of the conversation, and certainly one that we're spending a lot of time thinking about. I think we also recognize that we can't do that at scale or in perpetuity with just the resources of our health system. And so thinking about how we are extending beyond, responding with eviction assistance or food assistance, and really leaning into what are the larger systems that are causing this need to continuously present within our clinical care facilities. And so how do we get deeper into, again, underlying systems, underlying causes, and some of what we would consider and differentiate between social needs and social determinants. So thinking about that specific to food, here's a quick snippet of some of the food response. In my perspective, again, is pretty unique to our efforts in Southwest Ohio. But you're seeing a myriad of different initiatives that are underway. They're starting with how do we routinely screen for food insecurity as part of the clinical workflow? So how do we make this a part of the care conversation and acknowledge kind of the holistic nature of health? Simultaneously, as we're identifying those issues, how do we create point of care opportunities to enroll in food programming? So whether that be raising awareness of nutrition incentive programs, whether that be looking at nutrition prescription programs, or other avenues for encouraging that support for our patients when they are captive in our practices, and formalizing those relationships with partners that can really support those needs. Emergency food items available at our care sites. So, again, this is an acute need that presents, and there's an opportunity to provide, kind of a time-limited solution to a problem as someone presents in our ED or in a hospital site. Also, population-specific interventions. How are we thinking about nutrition as a piece of that larger kind of care need? How are we looking at the specific needs of populations by clinical condition, whether that be pregnancy or diabetes, and incorporating nutrition as a specific piece of that intervention? As we're moving down this list, then you're starting to see moving from that programmatic response and really into some of the work we're thinking about in the system space. So how do we invest in our local neighborhoods to ensure that they have the capacity to support the food needs of their local residents? And how are we leaning into that asset-based community development orientation to say, like, how do we find solutions that really work for neighborhoods? And we're going to talk a little bit about that in the spotlight on the next slide. But then I think even bigger than that, how are we appreciating our platform and really stepping into advocacy in a variety of different ways, whether that be, our government partners or our payer partners, to appreciate how do we work food into the conversation or other supportive mechanisms for these social determinants. How do we find long-term sustainable solutions to support these programs long-term? And then I think also in appreciating what's the larger role of an institution and an organization, how do we look at all of the different ways in which we're making decisions and appreciate the impact that has from a social, economic, and environmental perspective? So how do we look at our purchasing power? How do we look at our decision making and ensure that it's rooted in what we're intended to represent as a mission-based organization and a good neighbor in the communities we serve? Finally, I just gave one quick spotlight, and the team at Produce Perks really deserves most of the credit for this one, but just an example of kind of a local initiative that was multifaceted in one of our local Cincinnati neighborhoods, Sailor Park. Mercy Health has a school-based health clinic there that actually serves the community at large. It was a medical desert until that primary care practice went into the community. Similarly, it didn't have a grocery store within 5 miles. And so when we were thinking about how to introduce some of our nutrition prescription programming, there was a lot of additional energy around just looking at the food resources of the local community, and an acknowledgement that even though we could encourage nutrition incentive programming or prescription programming, there weren't a lot of local outlets or redemption sites to support that work. And so as we were moving through that conversation, we got a lot of really strong experted guidance from our partners in Produce Parks, who helped us identify and work with Gracely Food Mart, which was just a locally owned corner store that wasn't offering fresh produce at the time, but to provide some upfront capital enhancements and initial subsidy to start offering produce in that location. And so, you know, something we're really proud of as you move to the chart on this on the right-hand side of the page is just to see that while, you know, again, there were programmatic supports that were going in to support our patients, but a larger community opportunity to get, you know, healthy fruits and vegetables into a locally held resource. And in 2019, while they were offering barely anything, you saw that big jump in 2020 to, you know, over 5,000 in monthly produce sales, with a large percentage of those coming from Produce Parks and SNAP shoppers. And then I think even more exciting, you saw that sustained even a slight uptick in 2021 in terms of those produce sales. And so while it was a modest investment and kind of, you know, just an initial investment on Mercy Health side, you're seeing kind of a longstanding impact of the health system coming in and supporting the larger conversation around food. And so this is something that we're trying to replicate in other neighborhoods and in partnership with some of our food partners locally. So I'll pause there because I know we have a lot to get through today. I threw my contact information up here and we'll pass the torch back to Sarah, I believe.
Thanks, Gina. Next up, we have Courtney Hudson.
All right, so let's see if I'm sharing my screen. Yes, all right. Ooh.
I don't see anything yet.
Can you see my PowerPoint?
I think it's loading, yes.
All right. So I'm super happy to be here today to talk about some of the things that Akron Children's has done around food insecurity.
Courtney, would you mind putting that in presentation mode?
Oh,
so it's a little bit
all
larger.
right.
Perfect.
So are we good now?
Yes.
Sorry about that.
That's
perfect.
Okay.
So when Akron Children's first began to look at the issue around food insecurity, we began developing our strategy in 2019. And around that same time, we were awarded a Cardinal Health grant. So for Akron Children's, when we looked at addressing the emergent food needs of patient families, we were looking at families being seen in our primary care offices, and we defined emergent as they are out of food or they will be out of food within 72 hours. So in 2019, we began developing our food insecurity strategy. And at this same time, we were awarded a Cardinal Health Foundation grant in partnership with the Akron Canton Regional Food Bank. So our work was really focused in Summit County. So Akron, Ohio is where a lot of this work was taking place. As part of the Cardinal Health grant, we were really looking to re-engage patient families who had missed a well visit in the last year at one of our 3 primary care sites. And these primary care sites had high Medicaid rates for patients. And 1 out of the 3 primary care sites had a social worker as part of their team. So with the Cardinal Health grant, we were looking at being able to provide food to families. And one of the programs that we were able to offer was DoorDash deliveries. And we also looked at providing and distributing produce at community outreach events and drive-through events. So as everyone knows, in 2020, as we were really launching this work as part of the Cardinal Health Grant, our worlds were changing with the pandemic. So we had not really had a lot of time to launch the work as part of this grant. So like everyone else, we quickly pivoted. And what we started to realize was that in order to reach families, it was going to be community outreach events, drive-through style. Families stayed in their cars, and then we provided services. In 2020, we also began to work with Produce Perks Midwest to distribute fruit and vegetable coupons. Akron Children's also has a campus about an hour away from Akron towards the eastern part of the state in the Mahoning Valley, the Youngstown area. And that area had many grocery stores who were participating in the fruit and vegetable coupons. So we were able to really begin to do some food security work in an area that without the Produce Perks Midwest support, we would not have been able to. In Summit and Portage counties, we didn't have the grocery stores participating, so we were able to utilize the farmers markets. So as we moved through 2021, we started to we finalized our food security strategy. And then we also worked with the Akron Canton Regional Food Bank to launch our Fresh Track pilot project at the 3 primary care locations that we had identified. One of the things we realized was with our primary care sites, we thought that if we were able to connect families with a resource, that they could simply go online, identify a food pantry in their area, make an appointment, and then go to that pantry to get the food. We thought that that would be a pretty straightforward process. Like all best laid plans, and oftentimes with grants, what we thought was going to happen was not necessarily what happened. So what we quickly realized is that families who had screened food insecure, they were given the Fresh Track information. About half of them made appointments, and then we had even less show up. So during 2021, we quickly realized we really needed to reevaluate our process and approach for the Cardinal Health Grant. And then we also realized that our plan to really have a closed loop referral system was not going to work. Akron Children's, our social determinants of health screening is a paper version. Our medical record is Epic. And it took, what we quickly realized was it was going to take a lot of extra steps to integrate that social determinants of health screening if a family was testing positive for food insecurity into their medical records. Cardinal Health was able to work with us, and we really came up with a new plan for 2022. In 2022, we developed a pilot project with one of our primary care locations, and Locust Pediatrics is a unique primary care location. It serves a lot of medically fragile families. It's also a high Medicaid population, and it's also home to many of our immigrant and refugee families. Their children receive their primary care there. So we were able to launch a pilot program looking at English-speaking families and non-English-speaking families. When infants were brought to the practice as part of their newborn visit, the family was asked if they wanted to enroll in our food security pilot project. It would The pilot project would see the family through until their 6-month visit. As part of this pilot project, families were able to enroll in Fresh Track and be connected to the pantries. We also were able to provide a drop-off to the family's front door of food. These families were invited to food distribution events in the community, and they were also able to enroll in our United Ways 2-in-1 text campaign, and these families were able to receive 12 DoorDash deliveries of food. Some of the health measures that we were able to look at were immunization rates of the pediatric patients, completion of the well child visits, the Edinburgh screening for maternal depression, and then our program measures that we looked at were utilization of food resources, the satisfaction of the DoorDash program, and the satisfaction of the food pantries. Through this program, one of the things that we were able to do is hold a large culturally appropriate food distribution event in North Hill with, I would say that the Akron Canton Regional Food Bank was really open and really helped us to be able to provide food to the families that we served. So if you see, at this event, we were able to give families an option of what type of food they wanted. So they received a shelf staple food box of Asian and Hispanic foods. They also were able to, they received produce as well as some yogurt. And we were able to provide 300 of these boxes. And the only questions that the families had to answer when they arrived at this event was what type of food that they wanted and how many families they were picking up food for. So this is an aerial photo of the event, and this is we held this event at North High School, so we had lots of community support, lots of volunteers. And North High School, our local Akron Beacon Journal just did a story on the North High School football or soccer team today. And the soccer team has players from 12 different countries. They speak 16 languages, and 2 of the players are native-born Americans, so a very diverse school. And this is the community we held our food distribution event in. Moving on to other accomplishments in 2022, the Akron Canton Regional Food Bank was awarded an Ohio Department of Health Medicaid grant to support a food pharmacy pilot program in Summit County. You can see State Representative Amelia Sykes in this photo. Our food pantry will be located in a high traffic area of Akron children, so we are thrilled with that. And then at the hospital, we also opened an education and wellness garden this year. Some of the lessons learned from our project was a closed loop referral system was going to be very challenging. The social determinant of health screening is very challenging because we still are utilizing paper and pencil, and that does not integrate into the electronic medical records without lots of steps that are labor intensive. We really had to survey hospital staff on how their areas addressed food insecurity. And then we also surveyed patient families to see if they participated in our programs and what their experiences are. Community partners played an important role in this, and we needed to have identified champions along the way, from our team who distributed the Produce Perks coupons, and then to a physician who was passionate about ensuring that his patients received the food that they needed. And then also working to start our food pantry that is slated to open later this year. So we are super excited about that. A lot of hospital support was needed to be able to secure the location. It's going to be on the ground level of a building that patient families travel through all the time. So with that, I'm going to stop sharing my screen. And I will turn it back to you.
Thank you. Last but not least, we will hear from Leach with University Hospitals.
Hello, everyone. Let me just pull this up. Okay, you see my screen?
Yep, you're good to
Okay,
go.
great. All right, well, I'm excited to be here today to share with you how we at University Hospitals are addressing food insecurity as a social determinant of health. Let's scroll down, here we go. So since 2017, University Hospitals, in collaboration with Sodexo, has developed several programs that increase access to food and create more health equity. These programs were created to meet the needs of the surrounding communities in which University Hospitals serves. So as I think the first presentation we did here about community health needs assessment, we also do those every 3 years. Food insecurity has been identified in the last, at least the last 2 that we've done. So Sodexo oversees our nutrition services departments, and we collaborate with our other departments such as government relations, community impact, equity, diversity, and inclusion, as well as our Greater Cleveland Food Bank and our Akron Canton Regional Food Bank for a lot of our programs. The first one that I'll talk about are our Food for Life markets, also known as food pharmacies. We currently have 4 up and running. Our first one was implemented at our Otis Moss Junior Health Center in 2018. So actually, I think next week is our 4-year anniversary for being open there. This program, we screen our patients in the ambulatory setting. So they come in, see their provider. We ask them the 2 hunger, vital sign, food insecurity questions. If they screen positive to either question, they receive a referral to our Food for Life market. That provider referral is good for 6 months. The patient can visit us 1 time a month. We provide about a week's worth of food up to a family size of 4. We are different than a traditional food pantry in that each of our Food for Life markets are staffed by our community outreach dietitians. So we know what the patients are presenting with. A lot of our patients are coming in with hypertension, diabetes. We educate the patient as we walk the market. So it is a choice market where we provide fresh produce, lean meats, milk, and of course, canned items as well. So I mentioned that we have 4 locations that are open. Our newest one just opened this past May at Conneaut Medical Center. We are planning on an additional 3 Food for Life markets to open in 2023. We're also looking at outcomes with our Food for Life market. We have some research not yet completed, but we're looking at things like, increasing our primary care physician visits, decreasing our unnecessary ED visits. So at our main campus, Cleveland Medical Center, as well as Conneaut, we do also screen for food insecurity in the emergency room. We know a lot of our patients are presenting sometimes just for a meal, so we are connecting them with the Food for Life markets as well. We're also looking at our patients' health outcomes. So how are we controlling our weight, blood pressure, diabetes, looking at hemoglobin A1C. Our USDA Summer Food Service Program, we started this in 2017, I believe. So we're up to 7 UH locations. We provide this where we feed the children during the summer months when school is not in session. So since 2017, we've provided 36,000 meals to children. And I think too that this program is very well received across UH because we're feeding the children a hot meal. So we look at what our retail is serving for the day. We use our wellness item. We have a lot of families that come in for lunch, just for the lunch. They may not even have an appointment. And going back real quick, I forgot to tell you how many people we've served for our Food for Life markets, which is really great. We've actually provided 140,000 pounds of food to 7,900 individuals. So that's including patients and their family members. That is 2018 through 2021. Moving on to our Food as Medicine teaching kitchens. We have one at our UH Rainbow Ahuja Center for Women and Children, as well as Dave's Market that is across the street from there. Our community outreach dietitians, as well as our chefs, provide in-person cooking demonstrations. We also do grocery store tours. Each of these are recorded. We do provide them on our UH Healthy portal for our team members. And last year in 2021, each of the cooking demonstration and the store tour, there were over 30,000 views from our employees, so very well received. We do provide emergency food boxes. This is available to all of our UH employees that are in need, as well as our patients that are at the UH Rainbow Ahuja Center for Women and Children. We have another program that is out of our UH Rainbow Ahuja Center for Women and Children. This is our Healthy Harvest program. We provide a bag of produce to any patient that's leaving the building. So they're coming in for an appointment and they leave with a bag of fresh produce. It contains a recipe in there. Prior to COVID, we were doing cooking demonstrations at the center with whatever was in the bag, and we would eat the food and let them have samples to go. So most likely we'll be able to hopefully bring that back in the near future. We'll see, but that's another great program that's occurring. We have various group education classes that are going on. Again, these community outreach dietitians are teaching them. We had a homemade baby food class where we educated our moms on how to make their own homemade baby food. We provided mini blenders for them and food smashers. We partner with our dental clinic to talk about the importance of teeth and healthy eating. We have knowledge for life classes where we talk about nutrition as well as other things like healthy relationships and financial wellness. So all of these programs that we're doing here, they're all part of our Food is Medicine initiative. And that is actually all that I have right now. So I am going to turn it back to Sarah.
Thanks, Anne. Okay, so I'll open it up for question and answer. I don't see anything in the chat just yet. So I'll start off with the first question. I know this was touched on, but perhaps some of the presenters could expand upon common challenges faced when implementing social determinants of health and food insecurity screenings in your program areas. I know it's all a goal of yours, but what are the challenges to implementing this?
I can answer, I can go first. Yeah, so one of the challenges at university hospitals, currently we are, our ambulatory locations and our inpatient locations have separate EMRs. So while these questions and screening were built on the ambulatory side, it makes it difficult for our inpatient providers that are focusing on food insecurity to be able to refer to this program. Now we are moving to one EMR. We're currently working on that transition. So by next September, we'll all be on the same page, which is wonderful. But also I think another common challenge was the staffing. We're all faced with that, especially right now. How do you work that into the workflow? Who asks the question? As well as there were some education that we had to give the staff that they felt that asking patients about food insecurity would embarrass them. So just some coaching with the teams on how to ask the question and how to make them feel comfortable asking that question.
Yeah, I mean, I think Courtney echoed some of that in her presentation. I'd say similarly, finding space in the appropriate placement within the clinical workflow, and that extends out into the technology that holds the results and allows you to draw meaningful insights and introduce programming. And then I think true also the comfort level with asking questions, whether it be food or all the way to these other social determinant domains that, sometimes that can invite conversation that you're not having already. And not everyone, feels fully equipped to do that. So I think there is a lot of training there. I will also say, even though systematically doing this is new to health systems, these conversations have been happening forever. When you have patients who are in your care, you are identifying these issues, perhaps not through a systematic screen, but over the course of conversation as you're addressing barriers, whether that be in the primary care setting or through case management teams who are trying to figure out how to stably discharge someone from the hospital. So I think while structurally we're trying to figure out our way there, this has been a space that has been bubbling up within the health system for a while in terms of how do you best address some of the, the additional social needs of patients who are presenting in your care.
I think from the Akron Children's side, one of the things that as we were screening for the social determinants of health and food insecurity, we still don't have a food pantry. So once that opens, we'll have a more readily available resource for families. But I think that's one of the challenging parts, is that you're screening and asking these really important questions. And some of our teams felt like if a family was food insecure, what did they do with them at the moment? Some of our primary care sites have really gotten creative and have gone as too far as to create they would purchase resources and food for families when needed. So I think that it's one of those things of, again, just the education of the staff and figuring out flow and just how it all fits together.
And I'll just offer one thing kind of on the heels of that around what's kind of the immediate reaction, but then the long-term solution. And I think I appreciate what our care providers are saying, in that if I ask the question, I want to have something to offer, but also we need to build the strategies and the solutions and the capacities of the community to support that issue long-term, not just have something to offer. And I think we're dancing between those two worlds, right? Between, we're asking these questions. So is it good enough to have a paper referral to hand to somebody so we feel like, we've extended them to the next step, or is that actually going to solve the problem, because they're going to get downstream to a partner who potentially doesn't have the capacity to serve them. And so I think if you're thinking about it as a higher accountability to actually, get some resolution around the core issue, it becomes a much larger thing than just, to identify it and figure out, what's the first next step, and figuring out what our role is in each of those spaces is kind of important.
Really good responses. If you have anything that you'd like to ask any of those in attendance, please either raise your hand or put them in the chat. Another question I have is, what strategies have you all implemented to ensure that program services are accessible to all patients and community members? For example, addressing transportation barriers.
So I'll jump in then. One of the things that we've been able to do is work with our partners, whether it's the food bank or our United Ways 211, is to be able to provide the DoorDash deliveries. That program has really been a game changer. And I think that's one of the things that prior to the pandemic, I would never have guessed that we would have a system where DoorDash would go to the food bank, pick up food, and deliver it to families' front doors. Nor did I think that our department would ever participate in porch drops of food that we're able to get. But that's really been a game changer. And I think that that's also allowed us to, when we've had food distribution events and we've invited patient families, if they tell us that they are interested in attending but don't have transportation, we could arrange a DoorDash delivery of that food. So, thank you.
Yeah, similarly, I think a lot of our work in that space was actually expedited due to COVID, when people weren't going out and going into places. And so we did evolve some of our nutrition programming, and certainly if the team from Produce Perks wants to hop in here, feel free, because they would have be closer to the details, but, you know, to do produce delivery boxes and other things that essentially, instead of giving the vouchers or coupons, to be able to redeem those at certain sites, actually getting home delivery or produce boxes delivered to the primary care office so that they could get those fresh fruits and vegetables without leaving their house. And by extension, that kind of continued on to address the transportation barriers that still live beyond kind of COVID, because that solution and the mechanism to support it had been established.
Yeah, and I would agree. I mean, as we look to implement more, especially looking at our Food for Life markets, we're looking at, you know, is it close to a bus route? Making sure that there's some transportation access. We do provide things like Uber and Lyft. Our partners at the UH Rainbow Hoosier Center, they have something similar called Round Trip, where we could actually call and set up an appointment for our patients to be picked up, brought to our Food for Life market, and then taken home.
You. We do have a question in the chat, and then Lou, I see your hands raised, so we can go to you next. The question in the chat says, in what ways have you sought feedback from patients or participants on your programs? And have you made any changes based on that feedback? Good question.
Well, I thought we were talking about transportation and access, but we moved on from that.
Oh, I'm sorry. I was just going in order, but if that's a follow-up to the transportation topic, then go ahead, and then we can go back to the other question.
Oh, okay.
Sorry about that.
Yeah. A couple of things. When I started off in managed care dealing with Medicaid HMOs. And what we found is that a lot of time programs come out, but then the people don't have access to it. Like you said, they got to take transportation, 2 or 3 buses to get there. And so access is always a very important thing. What we've done, at least what we try to do, we have set up EBT farmers markets. And we set up EBT farmers markets in underserved communities close to the projects of public housing. And we train the people in public housing to run those EBT farmers markets so that we can get people enrolled in the EBT and use it correctly. And we're teamed up with a federally qualified healthcare plan and also a community health team to come out and do the screening, and where we would have the produce right there, and they within walking distance of their community, because the private transportation is almost non-existent, and they have to catch 2 or 3 buses to get there. And we found out that's better about putting the EBT farmers markets right there in the community. One, it gives them a chance to participate and develop EBT programs, can capture those EBT dollars, and also is accessible to them, and they don't have to catch 2 or 3 buses. And it keeps those EBT dollars in their community, and we can create economics right there in their community. And working with a community health team, where we could do health screening right there on the spot, and they can use the EBT food stamp cards right there at the farmers market.
Where are you located, Lou? Did you say?
I'm sorry, Sarasota, Florida.
Oh, Sarasota, Florida.
Yeah.
Thanks
Although
for
it's a
sharing.
high-income area, but we have a couple of areas in Sarasota that's projects and and low income.
Yeah, very cool.
Definitely seeing that theme of bringing the program or the food directly to where people are, instead of trying to find a way to get people to maybe the original site or location that programming was in place, especially with COVID. I think a lot of those processes across the board that have stuck around have benefited a lot of people. I'll turn it back to the question in the chat regarding have any of the speakers today within their programming made changes based on feedback from patients or participants?
Yeah, I can start. I mean, I think this is a really important question, and one that, you know, when we're talking about the needs assessment and generating input from the community around what the needs are, I think to extend that further and to incorporate it into every element of how the health system works, inclusive of how do you do iterative program design, how do you co-design programs with the populations who are going to use them. I do know, just as an example with the produce boxes, you know, we're asking the question, you know, about the contents they contained. Did they like them? Did they use them? Did they find them culturally appropriate? Were the recipes easy to use, and have kind of evolved, you know, the contents of those produce boxes based on the feedback that's been given, and tried to continuously evolve elements of the design to better support the needs of our patients. So love the question. I think it's happening, and I think there's just always room to incorporate that consumer voice in the design of our programs on an ongoing basis.
I can jump in. We've also tried to have that patient voice. So we were able to ask, really just to find out from the families who participated in our pilot program at Locust Peds, you know, what elements of the program worked for you, what didn't. Families really liked that DoorDash delivery. It was so convenient, especially with an infant. They didn't have to leave their house. And then the other thing was figuring out how to provide the culturally appropriate food for our families. We had to really be creative and figure out, you know, and ask the families what type of foods do they need and do they want. So I think that that's been one of those areas that our food bank was really great about jumping in and figuring out how do they get those resources. We know it's going to cost more to get them. And we were able to use some of the local markets here and really work with the community to provide those foods. And that's something we will continue with.
Yeah, and I would have to agree, working with our food banks, both the Cleveland and Akron. I mean, they've been great at, you know, we have monthly calls as a team with them. So constantly providing any feedback from our patients on items that maybe they would like to see at the market. We have flexed our hours of the dietitian because we know not everybody is available 8 to 5. You know, a lot of our patients work. So extending into the evenings in order to accommodate some of our patients as well.
You. I am getting the signal to wrap up so we can start the 3 p.m. sessions, but there is a really good question in the chat. So Roger, maybe if you want to put your email in there to have one of the presenters contact you about that question, I think that would be a great follow-up. Thanks again to Anne, Courtney, and Gina for their presentations. And thank you all for joining us today. We hope you found this session informative and inspiring. We hope you'll be joining us for more information throughout the afternoon. Once again, we've added the session titles and links to register for those sessions in the chat. If you're having any trouble registering or accessing Zoom, please contact Dana. And if this is your last session of the day, thank you so much for your time. And we'll follow up next week with session recordings, notes, and contact information. And we hope you've been inspired and intrigued by what you've heard today, and we look forward to connecting further. Thanks again. Take care, everyone.